All right. Okay. This is my financial disclosure. So the specific principles of dose reduction in chest CT or protocol optimization, it basically starts from comparing your chest CT doses with the same patient's abdomen CT, right? And then basically dividing the chest protocols by indications. And then basically that means that you have to know also what type of scanners you have, in addition to what the effect of changing the parameters has on the image quality. Well, so what's the fun in comparing chest with abdomen dose? Well, this is a dose page of the same patient where we have the chest doses and the abdomen doses, right? So the most important thing is that when we first started making the protocol specific to body region, we compared the chest and the abdomen doses for the same patient, and it turns out that the chest doses should be at least 30 to 50% lower than the abdomen doses if both are routine protocols. Right? So a routine chest or a rule-out chest or a general protocol chest should be about 30 to 50% lower than the same patient's abdomen. Right? So that actually will tell you if your doses of chest are the same as the abdomen, then something is wrong. So that's the starting point that I use. And then, of course, the lung nodule CT should have lower dose than the kidney stone CT, right? Because air in the lungs help with the contrast, and that helps you cut the dose down. And then the pulmonary embolism CT or the CT angiography of the thoracic aorta should have lower dose than CT angiography of the abdominal aorta, right? Again, a point that you can learn from comparing chest and abdominal doses. Well, so why is it that the chest CT should have lower dose than abdomen CT? Well, it's simple because chest has got lung, lung has got air. Air hardly attenuates the X-ray beam when it goes through it, and therefore it is not affected as much by decreasing photon flux or decreasing MA or decreasing kV as is abdomen, which is predominantly soft tissue and will have more effect on with decreasing dose. And the other thing that is favorable to the chest is that the blood vessels that take up most of the soft tissue in the mediastinum, like heart and all the big vessels in the chest, actually offer much better contrast than homogeneous low contrast structures such as liver or spleen or kidneys in the abdomen. So those two are the reasons why chest CT can tolerate higher noise and lower dose. Well, the most important scan parameters, according to me, the all-time winner is basically, the justification of the clinical indication. I think that's the most important part, right? And in MGH, we have the system that Dr. Brink actually alluded to in this morning, where all the physicians have to use what's called as the electronic radiology order entry system, which is a decision support system where the physician has to enter the medical record number, the age and the gender is then pulled up, and then basically he has to select what kind of exam does he want, and then what's the clinical indication for that particular exam that he wants, and the system will actually tell him, well, is the CT that he selected, was it appropriate? And this is basically based on the ACR appropriateness guidelines, which have been available for many years now. It will also tell the physician, well, what other modality can give the same information? For example, in this patient who had persistent cough, chest CT was returned as appropriate, indicated, with a score of 9, but so was the chest X-ray with the same appropriateness score. So if the patient has had a chest X-ray before, obviously the physician will choose to go with chest CT because it didn't add the information that the physician wanted. If not, he will basically get a chest X-ray. Now, the insurers, when they do the reimbursement of these exams, actually track the appropriateness score in our hospital, so that physicians who are consistently ordering exams with low utility scores have a lower reimbursement rates. So that's how they are basically forced to adapt and use the system. Since the implementation of the system in 2004, we have seen that the growth rate in terms of number of CT exams that we perform every year in MGH has been falling down. The point was that although the CT exams have been falling down since 2004, since we implemented this first, the MR and ultrasound examination follow the same fall in the growth rate, basically, which basically suggests that patients who did not get CT were not really getting more MRs or ultrasound, they were just not getting any imaging done. Or it may just suggest that there was overutilization, not only in CT, but equally in MR and ultrasound as well. Well, so as I said, once the appropriateness or justification of exam is settled, right, then we divide the protocols into different basically divide the protocols based on different clinical indications. Each division or each chest CT protocol at least should have, like a chest region should at least have 3 protocols. A routine chest, a lung nodule follow-up, and a pulmonary embolism CT. That's the minimum number of protocols that you want in your institution based on indication. Right? We additionally would have something like a diffuse lung disease protocol or high-risk CT. That's an additional protocol that one can have. And then, of course, you can have airway protocol, tracheal protocol, which should be clearly different from this diffuse lung disease protocol. The reason being, when you are talking about airways, like tracheal protocol, you're looking for big structures. Structures that can be this big, or at least a couple of millimeter big, and they have air surrounded by vessels or the wall. So very high contrast. So really you don't need the dose of diffuse lung disease to scan trachea. It's a big structure, right? So at least have 3 protocols in chest region. Lung nodule protocol, a routine chest, and pulmonary embolism protocol. And if possible, then you add the diffuse lung disease and tracheal protocol. So why do we need indication-driven protocols? Well, the reason is simple, because some things like lung nodules, like when you're scanning for lung cancers, or when you're looking at airways, you can use very, very low dose, as we will see in subsequent talks, and you can still see all the abnormalities and all the normal structures. And that's why you need to have special protocols when the area of interest is just the lungs. While others, if you're looking for anything in the soft tissue, for example, in the mediastinum, lymph nodes, a mass or a cancer in the mediastinum, you need higher dose, because again, there you're looking for low contrast structures. And that's why routine chest has to have a higher dose as compared to lung nodule or primary lung abnormality. So therefore, a chest lung nodule follow-up should be lower dose than a chest CT with contrast. Why do I have chest CT with contrast as lower dose as compared to chest CT without contrast? The reason is that when you are doing CT with contrast, you have higher contrast on board. For example, you have iodine on board, and then you can actually use your lower kV, enhance the contrast, and you will not be affected as much by the noise as you would be if you did not give iodine to the patient. That's why it would have lower dose. The doses for PE protocols can be, and in most cases are higher, for example, in our institution, as compared to routine chest protocol. And the reason for that is simple, that our slice thickness or image thickness is about half of what we would use for our routine chest. So you are looking at thinner structures. You are looking to find very small filling defects in very small vessels. So therefore, the doses can be higher with CT pulmonary embolism protocol as compared to routine chest protocol. Well, as I said, you have to know what kind of a scanner you have, the different vendors, right? And you have to know what's the slice format, right? Do you have just a single loaf, or do you have the full 320 slice scanner from Toshiba, right? That's very important, right? And then, of course, you have to know what are the ingredients, in my hamburger here. Does it have IR technique? Does it have AEC technique? What type of technique that is? So you have to know all of that. And this gets a little bit tricky. This is the easier part. Okay, well, I often wish that there was like a magical scanner with magical protocol where the scanner would automatically pick up 1024 stealth mode and don't have to rotate the gantry. There is no pitch to worry about, and would pick up the lowest MA and KV automatically. Give me a dose for chest abdomen with a 0.1 milligray. I don't have to worry about anything. That's not going to happen very soon, right? Well, that keeps us in job. Well, that's not going to happen very soon, but I wish there would be one day where we would have these kind of things where the doses are really very low. Well, in any case, while we don't have that, we have to worry about many things, right? This is hung. Okay. So first of all, localized radiograph. Previous talks have, emphasized on the importance of localized radiograph, how it is important to actually make sure that you acquire the CT localizer radiograph with proper centering, right? And I cannot overemphasize it, and therefore I'm not going to talk too much about it, but except to say that that's very important, and one should make clear that we do the localizers with proper centering because it has several implications on image quality. Well, most of the chest CTs you are going to do with helical mode, spiral mode, right? There are, however, instances or indications where you would use axial mode. For example, when you are doing CT-guided biopsies of the lung masses, we would switch often from a helical mode of acquisition to localize the lesion. And when we are just looking for localizing the needle, we would just scan maybe 2 millimeter or 5 millimeter just through the lesion to avoid overbeaming, to avoid excessive dose. We would dial down the kV, we will dial down the MA, and switch to axial mode or step-and-shoot mode of acquisition. Right? So this is one place where you would go for step-and-shoot mode or sequential mode, as some people would call. Now, the other place where we use axial mode is basically in diffuse lung disease or high-risk CT of the chest, where the first initial acquisition would be a volumetric coverage, which will cover the entire chest, basically. And the second acquisition, generally in expiration view, if it's needed, would be generally around slice thickness of 1 or less, and then you would only acquire it at every 2 centimeter. So you are just sampling 5% of the lung, right? Because the patient has been asked to expire, let the air out, exhale, and then you're just running few axial cuts. So that drops the dose significantly as compared to volumetric acquisition. Now, I do know of places, many places in fact, which would not do this method, who basically would do this full helical in inspiration, and then for their high-risk CT would do full expiration chest. If you want to do that and avoid multiplying your doses by 2, you have to reduce the dose for the expiration phase to as low as 10, 20, or 30 MAS. Otherwise, the dose would be very high. Now, scan length has an effect on dose. For routine chest, generally we begin just above the apex of the lung and extend to mid-liver or adrenal gland. But when you are going to be working with PE protocol or lung nodule or lung cancer screening or benign lung disease, you can actually limit your coverage to the mid-liver level. You do not need to go below that. The reason is that lung nodule and lung cancer screening are non-contrast studies. Non-contrast studies or studies without contrast or iodine does not really help you pick up liver lesions or other things. They are not that useful. And plus these two studies are so low dose that you're not going to get much information anyway below the lungs, right? So it doesn't make any sense trying to go and chase mid of the liver or all of the liver or trying to go to the adrenal glands, which is what you will be doing for routine chest, right? So you should be curtailing. For pulmonary embolism, it's important that you start just below the xiphoid process or just at the level of the top of the diaphragm and go up. And the reason is that if you have an older scanner, you can actually miss out the bolus, right? And that would lead to suboptimal study. And the second reason is that although you have iodine on board, you are scanning so early that the iodine has not had the time to go through the liver or the abdomen. So you do not want to go through the abdomen in those cases. Scan overlap, somebody alluded to this before, that scan overlap does lead to significant amount of dose when you are doing neck and chest CT or when you are doing chest and abdomen CT. Now, there are some protocols where you can actually, or where you should actually, be doing a single run chest abdomen. Trauma is a very good indication for that, where we do that routinely as part of our care, that we do a single run study from chest down to abdomen. Lymphoma is another place where we would do a single run chest and abdomen CT. We are not looking for lesions in the liver. We are looking for lymph nodes which can be seen in a single run, right? However, certain other cases where you have patients with cancer like colon cancer or kidney cancer or other cases, you cannot do a single run because the chest guys are not going to be happy when you do the timing for abdomen, and the abdomen guys would have nothing to deal with in terms of contrast if you do it according to the chest. So you have to split it. And then the only thing that we tell our technologists is to be good with breathing instructions, how to hold the breath in consistent phase so that they can minimize this overlap. Now, tube current, basically, in almost all the indications for chest CT, we should be using automatic exposure control technique. Same for abdomen, same for chest, except that when you are going to be doing a very low-dose exam, like lung nodule or lung cancer screening protocol, you can just do the same kind of a good job, but just low MAS, which can be fixed. 40, 50, 60 MAS is all that you need for lung cancer screening or lung nodules. And therefore, in those protocols where you're going to be using very low dose, CT colonography is another place. You can actually get away with fairly low dose, fairly consistent image quality by just using fixed MA. There's no need to go for automatic exposure control technique in those places. But for all other routine chest CT, PE protocol or other things, you have to use automatic exposure control technique. So basically, as I said, for pulmonary nodules, in pediatric imaging, when you're scanning just for lungs, or you're doing it for cystic fibrosis, lung cancer screening, you can actually use fixed MA and still reduce the dose significantly. For most other things, you have to use automatic exposure control technique, for example, for routine chest CT. And also remember that the dose reduction, when you're looking for mediastinal masses, or when you're looking for small lymph nodes, or when you're looking to stage a lung disease like lung cancer, you have to use a higher dose, not the dose that you would have used for your lung nodule. When possible, the arms should be placed above the head when you're doing a chest CT. If that is not possible, right, then you need to keep the arms on the top of the patient, right? And typically, what I suggest and what I recommend and what has been reported in the literature is that if the patient cannot raise their arm for chest or abdomen CT, you need to keep a pillow on the top of patient's belly, and then you need to keep the hands on top of that pillow. Do not keep the arms by the side of the patient. And the reason is that you would increase the lateral dimension of the patient. Right? Already you know that the noise in the image is affected by the projection that has the highest attenuation. If it was me, where my attenuation is maximum laterally, and if I place my arms like this, I'm doubling my attenuation. So not only am I increasing the noise, the dose, but also I'm going to cause more streak artifacts or more beam hardening artifacts as I go in this direction. Right? So that's something to remember. And also, if you do not raise the arms for the localizer radiograph, as in this case, right, if you do not raise the arms when you're acquiring the localizer, but raise it later during acquisition, there is no way the scanner would know what you did. The scanner is still going to think, while you scan, you're going to scan like this, and it's going to increase the dose. So you should do the localizer in the same plane or with the same position as you would do your axial images. Otherwise, the dose will be increased. Metallic prosthesis, again with automatic exposure control technique. Previous speaker, Dr. Mark Supanich, actually pointed that very clearly, that when you have metallic prosthesis, you may have to trim the maximum MA that you can apply with your AEC technique. Some vendors, like Siemens and Philips, you do not have to do that. A, you cannot do that in many of their scanners, and B, you do not have to do that because these vendors have identified the problem. When they see attenuation going above a certain point, they know there is metal, they know they cannot overcome those artifacts or image quality concerns with metallic implants, big metallic implants. I'm not talking about small clips or small screws, right? I'm only talking about big implants like either a humeral prosthesis or a big spinal rods or a hip prosthesis. Siemens and Philips would not allow their MAS to increase with metallic prosthesis compared to patients who do not have it. But for other vendors, you do have to trim. You do have to put a maximum MA that is lower. Otherwise, the MA will go up, but you may not note improvement in the image quality. Well, tube potential, we heard in the morning lecture by Dr. McNitt-Gray, that's very, very important parameter to adjust dose. And chest is one of the places where you should be using lower kV in addition to cardiac CT. Most of the cardiac CTs, for example, in our institution is done at 80 to 100 kV. Very rarely we will go to 120 kV in about 10% of the cases, and maybe 0.1% of the cases are done at 140 kV, right? In chest CT, same, right? Most of your chest CTs in patients who are average build or under should be at 100 to 80 kV, right? Certainly never at 140 kV, right? Unless the patient just is so big that I haven't seen one. So, but anyway, in children, for example, certainly children who are less than 50 kilogram, and we know Dr. Frush pointed out that he uses 80 kV even in children up to 70 kilogram. But in our institution, if children are less than 50 kilogram, 80 kV is sufficient. You do not need to go above that. For adults, generally, some people say that you can use 50-80 rule. That means any guy that is less than 50 kilogram can be scanned at 80 kV. Certainly true when you have CT that has been performed with contrast. May not be as much true if you do not have contrast on board. Right? Certainly for patients who are less than 80 kilograms or so, they can be scanned at 100 kV. And above that, you may need to increase your kV. But, rarely you would need 140 kV. That should be an exception rather than a rule. Right? And then lower kV should be specially used when you're doing a chest CT which is with contrast, and of course in most cases when you're doing a CT pulmonary embolism protocol, because those are the places where you have iodine on board. High contrast helps you see through the noise. Okay, well, in the morning, actually, we heard from previous speakers that they discussed about this automatic KV selection technique. I know Siemens has it, and I also know that GE plans to release this. I do not know about other vendors' plans, whether they have one or they are going to release one, but basically looks at the patient's eyes, looks at the point whether this is going to be done with contrast or without contrast, and then basically picks up the right KV. It does increase the MA a little bit because you have just dropped the KV, so in order to keep a reasonable contrast to noise ratio, it would increase the MA. Detector geometry, we also heard in the morning that wider is better. When you are going to be scanning longer areas, like chest, abdomen, or extremities, you should be using a wider beam width or detector configuration or beam collimation or beam width, right? In the chest, if you have a 64 slice scanner, I would use a bigger beam, right? If you are only doing a small part like a wrist or an elbow or a temporal bone, you can actually use smaller beam, narrower beam, right? You'll have less of the, because you're scanning over a smaller area, you'll have less of the overbeaming, and therefore the dose would be lower. Right? But in chest, in generally, wider is better. Okay? So you would be using a wider beam. Pitch, most vendors like Siemens and Philips, when you change the pitch, the MAS will change itself. In fact, they use something called effective MAS, and therefore you will not see any change in the dose. I only adjust pitch if I have to go faster when I'm doing something, right? Patient who would not hold their breath, or patients where you know that this patient has come for a suspected pulmonary embolism, he's going to be short of breath, and you want to go faster. That's where I would increase the pitch. I would decrease the pitch if you had a very heavy patient, right, and you were doing the CT of this patient on a machine that cannot go beyond, say, 400 or 500 MA. And there you want to decrease your pitch so that you can get better flux and you can get better image quality. Otherwise, I leave the pitch close to 1 for most of my chest CTs, right? And then I keep the pitch close to 1.4 for my CT pulmonary embolism protocol because I want to scan fast, right? So therefore, I decide my pitch based on how fast I want to go, not how low I want dose to be. Scan phases. In chest CT, fortunately, most of the chest CTs are done with a single phase, either non-contrast or post-contrast. Very rarely do we do both pre-contrast and post-contrast. One indication where we will do that is CT angiography of the aorta, right, where we would do a non-contrast CT to see if there is any hemorrhage or blood in the thorax, and then do a follow-up post-contrast to see the vessel itself. Right? But otherwise, most of the indications in the chest, you generally require only one. The other place where you would do multiple series is when you are doing diffuse lung disease or trachea, where you do both inspiration and expiration scans. Slice thickness. Well, slice thickness, if you look at this row of images, these images have been acquired at 150 MAS and CTDI of 10 milligray. They are all at 120 kV. And these images are at 40 MAS, CTDI close to 3. Right? When you are at low dose, you can see the difference between these two images. Obviously, this is 4 times lower dose than this one. Very noisy. You also see some holes. Right? These images are 0.75 millimeter. But when you increase the slice thickness to 3, look at the effect. Now the differences are less subtle. And when you increase it even further, the differences become even less. What that means is that you can acquire images at thin, you can look at them for troubleshooting, But when you interpret the images, you interpret them at thicker images, because that helps you cut down the noise, increases the acceptability. You are going to sacrifice some resolution, but in most cases, most places, including the protocols that have been submitted to us, basically use 3 to 5 millimeter as the slice thickness. In the abdomen, on the other hand, the effect is more profound, right? As you can see, at 180 MAS, 13 milligray, all the images, as you increase the slice thickness, you can see the noise drop down. But at lower dose, the noise drop is not that significant. It still is a very noisy image at 3 millimeter. 5 millimeter, maybe less noise, but it's still noisier as compared to what you see up here. A filtered back projection, basically, we heard about the iterative reconstruction techniques, have higher noise, lower artifact suppression. Some of the newer iterative reconstruction techniques can allow you to reduce the dose by about 30 to 50% or even higher with some of the newer techniques. They certainly can help you reduce the KV and increase the chances that your radiologists are going to like 80 or 100 kV, which they would not have liked with filtered back projection. Noise reduction filters, they have been around for many, many years. In the lungs, again, low dose has hardly any effect. Certainly not much effect up to 40 MAS or a CTDI of about 2 milligray or even 1 milligray in certain cases. Right? Noise reduction filters don't really add much in lungs. They would add something in terms of your soft tissue, but not much in the lungs. Unless you want to go even below 1 milligray, where they would start to have some effect. Iterative reconstruction techniques, Sarabjit did a very good job in the morning to explain this, but basically, again, to make a point that in the lungs, noise doesn't really have much effect. You can go from a CTDI of about 10 down to 2.5. You can still see all the abnormalities that you want to see. And although the Acer does denoise, and so are the other iterative reconstruction technique, really, this is as acceptable to me as this is. So in the lungs, really, iterative reconstruction techniques, unless you're talking about really low doses, under 1 milligray, they're not going to have that much of an effect. So, in summary, we should divide the protocols by indication, bin them at least in 3 or 4 dose bins. For example, lung nodules and lung cancers get the lowest dose. Then you would have your routine chest CT doses, and then followed by that, depending on what kind of slice thickness you use, you will have your CT pulmonary embolism protocol. Chest CT, again, can be done at substantially lower dose, at least compared to your routine abdominal CTs. And then, of course, appropriateness or justification of clinical indication is extremely important. Right? Once you have decided upon that, you need to make the indication-specific protocols. And then each individual specific protocol, you would size the dose by using the automatic exposure control technique in most cases. But when you are doing lung cancer screening or lung nodule imaging, you can use fixed MA. Thank you. Any questions, comments?
I was encouraged to see that you guys are using different KVPs for even different size patients, because at our institution some of our scanners can't scan at 100 KVP, and our radiologists wanted to read everything at the same KVP, so we're doing 120 for everything. So hopefully I can bring this back to them and say, well, other folks are doing it, certainly. Certainly it's possible, but especially, maybe they can't do what you guys can do there. But the question is, are there any issues that do come up or that you do notice reading the chest if they're done at different KVPs?
The use of lower KV has been reported from before iterative reconstruction era and for several years. And there is quite a lot of experience that we have collected using lower KV for the past several years, right? And certainly if you look at the pulmonary embolism literature, that has been coming since early 2000s, before any noise reduction filter or IR techniques were there. So we personally have not noticed any change. And in fact, one of the things that our radiologists tell us is when you have contrast on board, when you use lower KV, the images that they get, the contrast in the images they get is consistently so nice that they just wonder why the other patients are not small. So as to enable us to use the lower KV. And the other thing that we have noticed is that because of the cardiac CT practice, I recall cardiac CT, when we started doing them before 2005, that used to be our highest dose exam, right? Today, it is the lowest dose exam of all. And one of the chief reasons for that is that most of those CTs are done at 800 kV, right, compared to the rest of the body region. So that dynamic change, has basically we have taken our lessons from cardiac CT down to the chest regions, basically. And now we have certain protocols, even in abdomen, which are using lower kV. And you will hear tomorrow from Dr. Brendan Nelson as to how he is using lower kV in abdomen more and more with these iterative reconstruction techniques.